Welcome to Medscape. I'm Dr. Andrew Wilner, and today I have a special guest, Dr. Ron Petersen. Dr. Petersen is the lead author of a paper recently published in JAMA Neurology entitled A New Framework for Dementia Nomenclature. Welcome, Dr. Petersen.
Thanks, Dr. Wilner, for having me.
So, Dr. Petersen, you are a professor of neurology and an expert in the dementia field. Tell us about this paper. I read it, and it's pretty long and pretty detailed. There's a lot of, they talk about getting granular. It got pretty granular about
Right.
dementia. Why was it important to do that?
Well, it all began several years ago from the Advisory Council for the National Plan for Alzheimer's Disease. So a bunch of us were sitting around the table as we did 4 times a year in Washington, and it became clear that when one of us was talking about Alzheimer's disease, the person sitting next to you may or may not be interpreting Alzheimer's disease in the same framework as you have. And by that we came to realize that the terms are being used commonly: dementia, Alzheimer's disease, frontotemporal dementia, but people are not using them consistently. So the advisory council then charged a subgroup of us to go out and look at this issue, and can we add some clarity to it by trying to dissect how people are using these terms and bring some consistency to it. So with that as a backdrop, then we formed a committee of people from various walks of life who come across people with dementia, with cognitive impairment, with Alzheimer's disease, and we tried to see what were the issues that people were facing when they started using these terms. So that's sort of the backdrop of how it came about. And as we got into it, we decided we're probably going to need some subgroups to look at various issues. So we broke the overall committee into three subcommittees: one on research, one on clinical practice, and one regarding public stakeholders. And those groups met independently, discussed the issues back and forth, and then we would all get together periodically to share our thoughts and to try to see what the issues were and how we might address them.
Now, when you say everyone wasn't really on the same page when it came to terminology, was that physicians versus lay people, or was that even within the physician community?
Good question. Believe it or not, it's even within the physician community, it's even within the research community, and clearly among the public stakeholders. So we ran across a situation where people at a meeting, the scientists, if you will, at a meeting would say, we followed a group of patients who went from mild cognitive impairment to Alzheimer's disease. And we realized, well, that doesn't really make sense because mild cognitive impairment is a collection of symptoms, a syndrome, and Alzheimer's disease is a specific disease with biologic characteristics. So when we realized that that was happening very frequently, is still happening frequently, we tried to look at the big picture from the perspective of how can we simplify this. So we came up with a notion that when we're talking about any of these diseases, and again, we were charged by the advisory council who was dealing with Alzheimer's disease, dementia with Lewy bodies, frontotemporal dementia, and vascular cognitive impairment dementia, those four disorders, that we thought people should probably address these from a syndromic level and from a pathophysiologic perspective. So, take Alzheimer's disease, for example. We thought that perhaps people, when talking about Alzheimer's disease, should be clear. Am I talking about the clinical picture of somebody who has a memory impairment, maybe some other reading, thinking problems, and it's affecting my daily function? So it's dementia, and it's been going on for a long time, so it must be Alzheimer's disease. Or were people talking about Alzheimer's disease as a biologic entity? You have to have plaques and tangles in the brain or evidence of amyloid and tau through some biomarker to make it Alzheimer's disease. So once we appreciated that that was the crux of the problem, we then came up with a framework. And the framework really broke the diseases into the syndromic stage of the disease and the pathophysiologic stage of the disease. So again, with Alzheimer's disease, we ask questions: what cognitive domains might be involved? Memory, language, attention, executive function, etc. And then we graded each of those cognitive domains on severity scales, broadly speaking: none, minimal, mild, moderate, severe. We realized also that these diseases are not just cognitive. So we talked about behavioral features. We talked about motor features and some other features of these disorders, and asked the clinician then to outline the individual syndromic characteristics and grade them on a severity scale. Then we would come up with the clinical syndrome. If we have, and realizing that that is one way to describe the diseases. Again, on the other side, we have the pathobiology or the pathophysiologic characteristics. So, do we have any evidence that the person may have amyloid, tau, alpha synuclein, TDP43, vascular contributions, those features to characterize the diseases? And then we would ask the clinician to put together the syndrome, the pathophysiology, if we know it, put it together, and that's how we would characterize a disease. So we did not tell people how to develop criteria for Alzheimer's disease, FTD, etc. Rather, we just asked people to be clear when they're describing these entities as to whether they're talking about them clinically, pathologically, or a combination of clinical and pathologic features.
Oh, thanks for explaining that. That was very clear, and it sounds a lot like what we do as neurologists when we see patients. You get the history, and you try and define the syndrome. You don't have any test results yet, and then it kind of guides you. Oh, this patient has hallucinations before they have cognitive impairment. Maybe that's going to be Lewy body disease, or it's been going on for a long time. Maybe it's Alzheimer's disease. It started with memory. So the syndrome, that's very traditional. And then we get into the testing, skin tests for alpha synuclein or tau and amyloid. But yeah, I agree. It makes a whole lot more sense to kind of be clear about what
Yeah.
you're talking about. Now, was part of the driver for this, because there's always been this feeling, it's like, well, you have dementia and, it's too bad. And it was interesting for the neurologists to set up the nosology, but from a practical point of view, it didn't make a whole lot of difference. But now we're starting to see new treatments. Was that part of the driver to get all this sorted out?
It seems applicable now, but in fact, we started this exercise before the disease modifying therapies for Alzheimer's disease were available. But we anticipated that that would be the case, and hopefully for the other neurodegenerative diseases as well. So it becomes extremely important to try to characterize the patients clinically and then put it together with any of the underlying pathobiology you may know about, because ultimately, I think many of these cognitive disorders are going to require combination therapy, meaning if we have biomarkers that characterize in this individual, he or she has some amyloid component, maybe some tau component, but also an alpha synuclein component, we will now attack these disorders with perhaps multiple drugs. So it set the stage for that,
Mhm.
but in all honesty, it predated the development of the disease modifying therapies for Alzheimer's disease.
Right. So it does muddy the waters a bit that patients can have more than one type of dementia simultaneously. Is that right?
Absolutely. In fact, that's the rule these days, especially as you go up in age. Maybe in the 70s, it's a little bit isolated with regard to a single disease or a particular disease that is particularly impactful in this individual. But when you get to the late 70s and 80s, it's almost the rule that there will be multiple co-pathologies present. So whether somebody's going to respond to a drug may very well be dependent upon whether he or she has these other multiple morbidities. And I think that's going to be the case down the road, where wouldn't it be nice if when we go in to see our personal physician and the personal physician says, hey, we're going to do a lipid screen to see how your LDL, HDL, triglyceride levels are, and we're going to do a cognitive screen from your blood to see if you have amyloid, tau, alpha synuclein, TDP43, because hopefully we'll be able to treat them individually with therapeutics that are targeting those individual pathologic features. So it would be nice if we will be able to do that down the road, not today, tomorrow. But I'm thinking that ultimately that will probably be the road we're taking.
Well, that's pretty exciting. Now that the paper's published, how do you get the word out that this is the way we should do it?
Well, this was what we call the first phase of the exercise. The second phase of the exercise is now going to pilot this framework in actual clinical settings. So we're setting up a program where we will be looking at specialists, clinics, neurologists, psychiatrists, but we'll also be looking at primary care settings. And we will be looking at the way people do usual practice right now. And then we will give them some schooling with regard to, hey, how about if you use this framework where you describe the syndrome, then you look at some biomarkers and you help explain that to your patients and their families. And we're going to do pre and post testing with regard to understanding what's going on in the clinical setting with and without the framework. And we're hoping that the framework now is going to clarify the complex situation for the clinicians and for the patients and families, and the clinician communicating with the patient and families.
Dr. Peterson, you've done a terrific job in explaining this approach to nomenclature. Is there anything you'd like to add before we wrap up?
No, I think I'm hoping, again, we're not prescribing anything to anybody as to how to define these diseases. We're just trying to help people sort of reflect on how they do it. And I think it is going to enhance the communication among scientists, among clinicians, and hopefully with patients and families.
Dr. Peterson, I want to thank you very much for joining us on Medscape.
Thanks, Dr. Wilner. Appreciate it.